Welcome, everyone. My name is Anastasia Dodson. I'm here at the California Department of Healthcare Services. Welcome to the webinar. This webinar is for anyone. We are glad you're here. Whether you're someone with Medicare, you want to learn more about Medicare, you work at a health plan or in a provider's office, you work with older adults, or you just have a passion for these issues. Thank you for joining. You may be a researcher, you may be working for a foundation. We're glad to have everyone here on this webinar today, and very excited to be talking about this topic. Here at DHCS, we have an Office of Medicare Innovation and Integration, where we are partnering with the SCAN Foundation, thanks to their support for ATI, who's done this excellent analysis. So welcome, and we're gonna dive right in. Next slide. So again, my name is Anastasia. I work at the Department of Healthcare Services. We are the state agency that administers Medi-Cal. And we are joined by Nils Franco and Dr. Carla Perissinotto. And we'll do a little more detailed introductions for them shortly. But on the next slide, let's talk about some of the housekeeping. So all of you are muted upon entry so that we don't get the background noise. This webinar is being recorded and will be posted on the DHCS website. To access the chat, you can click on the chat button on the lower right corner of your screen, and you'll see a little picture of that on the right-hand side of our screen right there on the slides. And we're trying to only take questions via chat for the webinar, but if we need more clarification, we can take you off mute if you raise your hand. So the button to raise your hand is at the bottom right of the screen next to the emoji icon. And for anyone who needs live captioning for today's webinar, we have a link for assistance. So please look at the chat for that link, or you can also use the CC button, which again is at the bottom there. The agenda is posted on the DHCS website, and the slides as well as the chart book will be posted there shortly. And you can see that link, dhcs.ca.gov, and then there's a few more words there, and then you get to OMI, O-M-I-I. And you can even, once you get to the DHCS website, search for OMI, O-M-I-I, and that will get you to the page with the agenda. And again, we will post the slides and a larger chart book. All right, next slide. So what are we going to cover today? We have a wonderful analysis of chronic conditions among Californians with original Medicare. And we're going to take the topic into two sections, so we can kind of have some Q&A on the first section, and then we'll have Q&A on the second section. So the first section is about what chronic conditions are most prevalent and what are the demographic and geographic differences. And again, this is a data analysis, and Nils will tell you more about that, but this is an analysis of Californians with original Medicare, and the data is from 2021. So we'll go through that first section, do some Q&A and discuss with Dr. Perissinotto, and then the second section is going to be about cognitive and behavioral health, regional data, and dual eligibles. All of those, again, very interesting topics, more Q&A. And then, again, want to note that the chart book itself, which has even more about all of this, is going to be posted. It says is posted, but will be posted shortly. Same with the slides. One more thing about the data and what information is available. California Health and Human Services Agency has what's called the Open Data Portal. And in the coming weeks, we are going to be posting even more data files related to what you will see today. So a lot of the slides are looking at the statewide level, but for anything that you may be interested in here on a regional level, Los Angeles, Orange County, San Joaquin Valley, Sacramento area, Bay Area, the data specific to those regions is also going to be posted on the Open Data Portal. So this is the beginning of the conversation, and over the next few weeks, we'll be posting more information. And so we hope that these these documents will be, you know, in your consciousness and available for discussion. Today will be a great discussion, but then in the coming weeks and months, because this is really important data to get published. Next slide. So we're very pleased to have Nils Franco here. He's an analyst at ATI Advisory. ATI is a research and advisory services firm that works to transform the delivery of services that promote the health and well-being of individuals with complex health and social needs. We're also very pleased to have Dr. Carla Perissinotto, who is a physician, professor in the Division of Geriatrics, a geriatrician at the Department of Medicine at the University of California, San Francisco. And then I'm here from DHCS. Next slide. And then one more reminder before we dive into the data and information. So if you have a consumer question, if you have Medicare and you have a question about how do I use my Medicare, whether it's questions about health plans or concerns about anything else, questions, your local HICAP office is available to help. There's an 800 number on the screen that you can call and find your local HICAP office. You can also go to the California Department of Aging website, find services in your county, and again, HICAP can help. There's many other help resources for Medicare. There's a 1-800 Medicare line, 1-800-633-4227. Okay, next slide. All right, Nils, I'm going to hand it off to you. Thank you so much.
Well, good afternoon, everyone, and thank you, Anastasia. I'm honored to be here with each of you today to discuss the chronic conditions that are most commonly experienced by Californians with original Medicare. And we'll go into some of those terms and labels in the next few slides. But my name is Nils Franco, and as Anastasia mentioned, I'm an analyst at ATI Advisory. And the insights I'll share with you today are from a chart book prepared by ATI Advisory for the Office of Medicare Innovation and Integration that will be published shortly. So in the next few weeks, there will also be that open data set, and we'll show some of the insights today that will be from that data set and go beyond the contents of the chart book. So we have a packed schedule. So let's turn to an agenda of topics for this segment on the next slide. So briefly, the topics I'll cover in this first half of the webinar includes an overview of the Medicare program and of how Medicare intersects with Medi-Cal. And we'll look at the top 10 most common chronic conditions and then deep dive into differences in the prevalence of these conditions and total spending by the Californians with original Medicare who have these conditions. We'll look at differences in terms of demographics like age, gender, and race or ethnicity, and by rural-urban geography. Next, let's review some Medicare topics and terms. On the next slide, we have a review of Medicare and dual eligibility terms, starting with Medicare. So Medicare is the federal program that covers healthcare for about 7 million Californians today, and about 6 million that you see in that larger circle on the right in 2021. So in 2021 is the study period for today's data about chronic conditions. Medicare covers specific groups of people across the US. So people age 65 or older, people with long-term disabilities, and people with end-stage renal disease, among others. Original Medicare, this second bullet, is the Medicare program where the government, not health insurers, sends you a Medicare card and pays healthcare providers directly. In California, about half of Medicare beneficiaries, 3 million, have original Medicare. The other half have Medicare Advantage or related programs, and those are the other Medicare programs where a health insurer or some other entity like your employer administers Medicare benefits for people who choose to enroll in their Medicare Advantage health insurance plan. So today's analysis is going to focus on the original Medicare program and the population who have that coverage. On the next slide, we'll talk about how some of this intersects with Medi-Cal, which is the Medicaid program in California, and that program may also cover Medicare beneficiaries. When that happens, we call the individual who has both benefits a full dual beneficiary in this analysis. And Medi-Cal is a program that primarily serves people with low incomes, but other populations as well. And that brings us to the new full dual beneficiaries label. And one thing that you see in the Medicare data here is that plenty of Medicare beneficiaries enter Medi-Cal each year. And when someone with Medicare gained Medi-Cal coverage during a year, such as 2021, we call them new full dual beneficiaries. So in this chart book, that would be someone who entered or gained Medi-Cal coverage during the year of 2021 and had Medicare throughout that year. So why does this population matter? Well, when we get to segment 2 of our presentation today, we'll talk about how chronic conditions that are especially common among people who gained Medi-Cal coverage may be indicators of the medical and financial challenges that may precede Medi-Cal enrollment. And so we'll find some interesting chronic condition dynamics for those two populations, folks with full dual benefits and those who entered Medi-Cal during the year. So those are some key terms to have in mind. And on the next slide, we'll just have sort of wrap up and view of the population back in 2021 with both programs. So on the next slide, we've got 6 million California Medicare beneficiaries. 3 million in the left-hand side have original Medicare, and the remainder have Medicare Advantage. Original Medicare covers those folks, and then we've got a separate circle on the right-hand side where 1.5 million Californians have full dual benefits, have both Medicare and Medi-Cal. And of those, 819,000 also have original Medicare. So they're in the population that we're able to look at today in this study. And that in the middle will be a topic that we'll bring up in the segment 2 of this presentation. So now that we've done this table setting, I'm going to start sharing the chronic conditions data. And we'll primarily talk about original Medicare, but I want to pause here to just note that we're doing that because comparable analytics were not possible for the Medicare Advantage population. And so original Medicare data allowed us to look into these questions. But it's worth noting that while we focus on original Medicare here, the Californians who have Medicare Advantage also live with chronic conditions that may warrant attention. And so on the next slide, we'll look at some of our findings and the data that we looked at. So we're going to talk about the top 10 most common chronic conditions among Californians with original Medicare. But let's first talk about the data source. So we analyzed a selection of 38 chronic conditions identified in Medicare data by the National Chronic Conditions Warehouse, or CCW. And this study used that data source for 2021. And we looked at original Medicare beneficiaries who ended 2021 with 1, 2, or 3 years of having had continuous enrollment in original Medicare. So that's consistent with how the CCW requires multiple years of data for use in identifying chronic conditions. Note that these definitions look for chronic condition diagnoses. So that means that access to a diagnosis may affect the detection of the chronic condition. And that's a common limitation of this type of analysis that applies to this study as well. So that's some place setting again, and now we'll get into the summary of the findings here. So let's start with a quick comparison between California and the rest of the US. So among original Medicare beneficiaries, Californians were less likely than the rest of the US to have 8 of the top 10 most common conditions that we'll talk about in the next slides. And I think we're one slide too far down. So if we go back one slide, we should be, there we go. So that's that first bullet, that Californians with original Medicare have a lower likelihood of having these conditions than the national population with original Medicare. That's one key finding. Now, the second bullet is that in California, the top 10 most common conditions range from chronic kidney disease with a prevalence of 18% to high blood pressure with a prevalence of 63% among Californians with original Medicare. And after calculating how many conditions each person had, and this is the third bullet, we found that more than half of Californians with original Medicare had 4 co-occurring chronic conditions. So in other words, the typical Californian with original Medicare had 4 diagnosed conditions out of the 38 that we studied. Next slide, we have a few more key findings. The first of which is that we found that the top 10 most common conditions were generally more common in urban areas compared to other areas. And we found that they were generally more common at older ages. Now, we also saw, relatedly, variation in the prevalence of these 10 most common chronic conditions by gender or sex and by race and ethnicity as well. But we'll show that to you soon, but no sex or race or ethnicity group was consistently seeing higher prevalence across the 10 conditions. So it varied from condition to condition in a way that wasn't true for age groups or geography. And we'll look at that in just a second. Lastly, and this matters because Medicare spending correlates with out-of-pocket spending, Medicare spending was generally higher among certain groups, and we'll look at that as well. Total Medicare spending for people with the conditions was generally higher for men than for women, and in urban areas than in semi-rural or rural areas, and at ages under 65 compared to those 65 or older, and also among Black beneficiaries compared to other beneficiaries. Now, if you think about Medicare spending, it includes things like hospital stays and ER visits or nursing facility stays, which may be covered by Medicare. And these often expensive experiences for the individual reflect or may reflect the medical complexity that people are managing with their chronic conditions. So you'll see that spending information on the following pages right next to information about how common a given condition is in a population. On the next slide, we have the top 10 most common chronic conditions. And here we have high blood pressure experienced by 63% of the Californians with original Medicare in 2021. High cholesterol, similarly, 62%. And then going down the list, there's a big drop off after that, with arthritis affecting 33% of Californians with original Medicare, diabetes, 28%, cataracts, 24%, and so forth, with anemia, chronic pain or chronic fatigue, hypothyroidism, coronary heart disease, which you'll see abbreviated as CHD, and chronic kidney disease, abbreviated as CKD. And those 10 conditions are the most common that we identified among Californians with original Medicare. Now on the right-hand side, you see the number of times more Medicare spending those with the condition experienced during the year compared to the statewide Medicare spending on average for the original Medicare population, which was $14,525. So just to interpret this very briefly, among people with anemia, Medicare spending was much higher on average than the statewide Medicare spending overall. 2.6 times higher, in fact, or 2.6 times the average Medicare spending experienced by people with anemia compared to those overall with Medicare in the state. On the next slide, we'll look at a series of analyses over the next few slides by demographic group and geography. And let's walk through the meaning of these charts. You'll see 4 bars here for each condition. So let's look at the prevalence bars on the left next to the name of the condition. And as an example, among Californians with original Medicare, 46% of those younger than 65, which is that top dark blue bar, and you see the legend in the bottom right corner, 46% of those younger than age 65 have high blood pressure, compared to 80% of those 85 or older, which is that yellow bar, the 4th bar for high blood pressure at the bottom there.
Nils,
Going down the list here.
Sorry, Nils, this is Anastasia.
Yeah.
I'm going to interrupt you for 1 second on the spending, on the Medicare spending. Your example about anemia, I think just might be helpful for folks if you can remind them that Even though someone with anemia as a chronic condition may have that larger spend, it counts for all of their Medicare spending, not just the spending related to anemia. Is that right?
That's right. So this is the total Medicare spending experienced by the population represented by the bar. So if we went to the prior slide, we'll see an anemia, and that represents the total Medicare spending by Californians with original Medicare who have anemia in the year. And their Medicare spending overall, not just the Medicare spending that's caused by their anemia and related care, their overall Medicare spending, which may be associated with other conditions as well, was 2.6 times the statewide average for Californians with original Medicare. And that's a really important point. So thank you, Anastasia. Going back to the age group comparisons here, it's going to be the same story where the spending comparisons are for total Medicare spending for that population. So focusing for now on the prevalence side, on the left-hand side of this graph, we see that the populations with older ages live with many of these conditions more often than the younger populations with original Medicare. This may be the result of conditions accumulating as people age. And on the spending side, the bars on the right that we were just discussing, we have the average total original Medicare spending for each age group compared to the spending for all ages with the condition. So as an example interpretation here, the first bar shows that 1.5 times that you see there for those younger than 65 for high blood pressure. So what does that mean? This means that among Californians with original Medicare and who live with high blood pressure, the average Medicare spending per person per year for those younger than 65 is 1.5 times the overall average, where that means for Californians with original Medicare who live with high blood pressure at any age. Going down the list here, we see a consistent theme where those who are under 65 or who are 85 or older experience higher average Medicare spending compared to those in the age range of 65 through 84. Next slide, please. So now that we've introduced the meaning of these slides and the ability to make comparisons in this way, the next slides are going to be about age group, sex, geography, and race and ethnicity. And here we have the 6th through the 10th most common conditions, the next 5 most common, split by age group. So this is a continuation from the prior slide. You'll note that those who are age 85 or older experience anemia, coronary heart disease, that's CHD, and chronic kidney disease, that's CKD, twice as often or more as compared to those who are ages 65 to 74. So we're comparing here the yellow bar at the bottom for each condition compared to the lighter blue bar, the second bar for each condition. You'll note that those who are younger than age 65 experience chronic pain or chronic fatigue more often than the rest of the age groups. Medicare spending on the right-hand side is distinctly higher for those under age 65 among the populations living with coronary heart disease and chronic kidney disease, CHD and CKD in particular. Next slide, please. So now we have a comparison by sex or gender, and there's not much of a difference in prevalence for some conditions here, but you'll see particularly higher prevalence of arthritis among female beneficiaries compared to male beneficiaries. And male beneficiaries generally experience slightly higher average Medicare spending compared to female beneficiaries with the same conditions. So here the comparison is that I want to draw your attention to and interpret is arthritis, where we see 38% prevalence among female Californians with original Medicare compared to 27%, a lower percent prevalence among male beneficiaries with original Medicare in California. Next slide, please. The next 5 most common conditions are here, again split by sex for the Californians with original Medicare, and where we see female beneficiaries more often living with chronic pain or chronic fatigue and hypothyroidism. Coronary heart disease is more commonly experienced by male beneficiaries. So that's that CHD condition on the left here. The only condition for which female beneficiaries have higher rates of spending compared to male beneficiaries with the same condition is coronary heart disease. And so the difference here is not very large, but you see that the blue bar here for CHD is slightly larger than the yellow bar, which represents the relative spending for female beneficiaries compared to male beneficiaries. Next slide, please. So here we have now a comparison by geography. And of the 10 most common conditions, urban residents are more likely than rural residents to have each condition. On this slide, the most notable difference is diabetes prevalence, with 28% of urban Californians with original Medicare having diabetes, 28%, compared to 24% of semi-rural residents and 22% of rural residents. Cataracts prevalence is fairly consistent between urban areas, semi-rural areas, and rural areas in contrast. So this provides an opportunity, and you'll see this in the chart book that will soon be published, to really deep dive condition by condition into how the frequency or prevalence of these conditions varies by rural or urban area, or may not, right? As we see for cataracts, for instance, with a relatively small difference there. In general, Medicare spending for people with each condition is higher among urban residents than rural residents, which may reflect some mix of higher utilization of medical care or higher care prices or more complex care needs, something that might be investigated in the future. And on the next slide, we'll see a persistent trend from the prior one, looking at the next 5 most common chronic conditions and split again by urban-rural geography. So the most notable difference in prevalence here is anemia, affecting 1 in 4 rural residents, 24%, compared to 1 in 6 urban residents, 17%. Chronic pain or chronic fatigue is the only condition where it's more prevalent in semi-rural areas than in urban areas. And this condition, as well as hypothyroidism, don't vary in prevalence much between geographies. So fairly similar prevalence between geographies, in contrast, for instance, to anemia, where there's some differences between urban areas and more rural areas in the state. So with that, that's the geography analysis. And up next, on the next slide, we'll have condition prevalence and spending by race and ethnicity for the 4 most common conditions. And then we'll go into the next 3 and the next 3. So for the 4 most common conditions shown here, for example, for high cholesterol, about 2 in 3 Black beneficiaries or white beneficiaries have high cholesterol. So 2/3, 68% and 63% respectively. Compare that to just 1 in 2 Hispanic beneficiaries or American Indian or Alaska Native beneficiaries, abbreviated AIAN in the legend in the bottom right, which both groups have a prevalence rate of 51% for high cholesterol. For another example, 39% of Asian beneficiaries and of Hispanic beneficiaries have diabetes, whereas lower percentages, for example, of white beneficiaries have diabetes at 22%. Black beneficiaries experience the highest Medicare spending compared to the overall average for each condition across this and also the next 2 slides. So on the next slide, we'll look at the 5th through the 7th most common conditions. So just moving down the list, split by race and ethnicity. What we see again is that there is variation, but there's no consistent story across the conditions. Each condition seems to have its own unique pattern of racial and ethnic differences in prevalence, which may warrant further research and discussion. For example, cataracts are most common among white and Asian beneficiaries at 25%, and anemia is most common among Black beneficiaries at 30%. Chronic pain or chronic fatigue, marked as fibromyalgia here, is most common among American Indian or Alaska Native beneficiaries at 28%. On the next slide, we'll look at the final slide in this segment. Here we have the 8th through the 10th most common conditions split by race and ethnicity. And for example, hypothyroidism and coronary heart disease are most prevalent among white beneficiaries, while chronic kidney disease is most prevalent among Black beneficiaries, where CHD means coronary heart disease and CKD means chronic kidney disease here. Now, the important thing here is that we're seeing a unique pattern, condition by condition, of racial and ethnic differences in prevalence, but a consistent higher spending among, higher Medicare spending among Black beneficiaries, which corresponds or correlates with out-of-pocket exposure. So higher out-of-pocket costs may come along with higher Medicare spending for these populations of Californians with original Medicare who are living with these conditions. So I think with that, we can move to questions and then to the next segments of these slides. And I'll hand it back to Anastasia here. Thank you all so much.
Thank you so much, Nils. Very good, very interesting data to look at and think about. Let's go to the next slide with the questions. We're gonna, first of all, let me open it up. Anybody who wants to ask a question or raise a thought on any of this, you can, type into the chat. Also, you can also raise your hand if there's something that is more in-depth where you want to come off mute. But I will ask, oh great, yes, Dr. Perissinotto, do you have any kind of initial thoughts on this data? Like what's most interesting, implications for clinicians?
Yeah.
It's great.
Well, one, I just want to congratulate the team on such an incredible reporting of results. I can only imagine the amount of work. And I think that there's a couple things to be celebrated. One, I think, Anastasia, as you know, and I were talking earlier, that California has done well, better than other states or other Medicare beneficiaries. And so that leads me to hope that we're doing better with prevention, which is certainly a public health priority earlier in the life course. So I'll start on the positive note there. I will now put on my cynical hat, and then I'll put on my hope for the future hat. And my cynical hat is that so much of this data is dependent on what clinicians, physicians, nurse practitioners, and PAs are actually writing in electronic records and charts. And we have a long way to go in terms of accuracy, and completeness. And I think we'll see some of that in some of the further data that you're going to present. And so I do have some questions in terms of some of the rural and urban areas and concentration of academic medical centers, or how are we doing as clinicians is actually appropriately identifying and coding. To be frank, sometimes because our electronic medical records are so overburdened, it may be, for example, that as a clinician, I write coronary heart disease, but I don't write a separate hyperlipidemia or cholesterol problem. And so there's some nuances to just tease out there in the future, and this is for clinical things. I think as we move into the future, what this means is that we still have Medicare beneficiaries, whether they are traditional Medicare or Medicare Advantage or duals, that are living with multiple medical problems. Why is that important? That is important because we need a workforce that can care for this complexity, which means that as a clinician and as a geriatrician, I can't think of my older adult as only with coronary heart disease or only with hypertension. I have older adults with many of these conditions, which means thinking about their overall spending and their well-being and their health span is so important in terms of what is my knowledge and ability to care for these. And so as we emerge from this pandemic, where we know there's been a lot of burnout in clinicians, what is our primary care workforce doing? How are we training in geriatrics education? So that's where I think there's a lot of future discussion. And similarly with care coordination, what we'd love to see on subsequent analyses is, of these folks with multiple chronic conditions, are they seeing multiple specialists? What does that care coordination look like? And as we know, the topic du jour these days, though not a new topic, is social determinants of health. And so are these impacting people's ability to cope, get adequate care, and what are the other modifiable things we could be doing to addressing some of these conditions. So I'll pause there. I think there may be some questions in the chat, but I could go on and on, but I think maybe that's a little bit of an overview of how I look at this incredible data and how we move forward.
Wonderful. No, great thoughts. It feels like a conversation that could go on, and it will, I think, has been for months and years and going forward too, to digest all this data. Nils, there's a couple questions from Michelle Kupich in the chat around prevalence and spending and overlap and condition. And then another question about why CMS is using high cholesterol and hyperlipidemia. I think that goes to our translation of the, how did we ask you to prepare the slides versus what does the CMS data say?
Right. So happy to address Michelle's questions here, and thank you. So the chart book will go into further detail about the typical number of co-occurring chronic conditions for the individuals who live with each condition profiled. So for each of these top 10 most common conditions, you'll see how many co-occurring chronic conditions are typical for the individuals who have that chronic condition. So for example, number one most common condition is high blood pressure, as you saw. For the profile of high blood pressure that will be published in the chart book coming out soon, you will be able to see the number of co-occurring chronic conditions for the typical Californian with original Medicare who has high blood pressure. And we're really excited to share that. One thing that's important is that for example, we highlighted the higher amount of Medicare spending for the population who have anemia, right? And there may be other co-occurring chronic conditions that are driving the higher spending there, not just the anemia. And we wanted to capture the total Medicare spending. And so there is overlap and contribution of other complexities and conditions for these individuals. And that's captured in the overall average Medicare spending that we're presenting. And we want to be very clear about that, but that is also consistent with the data that CMS, the Centers for Medicare and Medicaid Services, publishes about chronic conditions in the Medicare population as well. On the topic about the labels here, we have a full description of how we converted labels into from the true conditions that CMS is identifying using diagnoses. So for example, CMS is actually identifying hyperlipidemia, which is a bigger category than high cholesterol necessarily. But then we use labels consistent with what CMS uses in their infographics for public-facing material. So we're calling it high cholesterol to be more public-facing, consistent with what CMS does. But we are actually measuring hyperlipidemia. And so hypertension as opposed to high blood pressure, for example, hyperlipidemia as opposed to high cholesterol. So that will be clearer in the chart book as well. Yep.
Great, great. I really encourage anyone who's part of the audience today to feel free to chime in the chat. I know Nils, thank you. Very good description of how the numbers work and the definitions per CMS. But if anyone else who maybe doesn't have any kind of a technical background wants to chime in, your comments are welcome about, again, having multiple chronic conditions, how that works navigating across different providers, different specialists. We're certainly not going to solve everything or make everything sort of more streamlined just with this webinar, but we do want to kind of keep both the numbers and the people in mind as we're going through these webinars, going through the data here. So, okay, so with that, we're right on time to move on to the next section. But again, anyone can feel free to chime in on the chat, whether it's questions or the thoughts about how this data could be used in the future, different webinars, different analyses. All right, Nils, I'll hand it back to you.
Great, thank you. So on the next slide, we'll just briefly transition to segment 2. And thank you, Anastasia, and thank you, Dr. Perissinotto. And this segment will provide some further analytic detail on the topics on the next slide. So 2 topics primarily, that's cognitive and behavioral conditions, and dual beneficiaries who have both original Medicare and Medi-Cal on the next slide. And so we'll also show you a map, and this is the middle bullet on the slide to come, that demonstrates how the analytics we're showing today can be examined at a regional level. And in this case, we're using the covered California regions, which are consistent with other materials from the Department of Healthcare Access and Information. So on the next slide, we have a quick note about the methods and then the top line findings from our data. So note that the methods here are the same as before. And as we move into the top line findings, we looked at Alzheimer's disease or related dementia, that's ADRD, and drug use disorders and depressive disorders as 3 cognitive and behavioral health conditions of interest that are measured by CMS and the chronic conditions warehouse. For the first, ADRD, we found that while 8% of Californians with original Medicare live with the condition, Alzheimer's disease and related dementia, the condition had 214% higher Medicare spending per person year compared to the state average of Medicare spending, which was, again, $14,525. So 214% higher than that for the average Medicare spending for the population with ADRD. And we'll plot how prevalence of ADRD varied by covered California region with some interesting variation in a future slide. Moving to drug use disorders, here are 4% on the next slide of Californians with original Medicare, which is 1 in 25, that 4%, have drug use disorders. And Medicare spending, again, was 161% higher for people with drug use disorders as compared to the state average. Drug use disorders are a brain disorder where the recurrent use of drugs causes impairment affecting health, disability, and life responsibilities. And we'll see some important analytics on that in just a second. Moving to depressive disorders, which includes depression and bipolar disorder, among others, 18%, or about 1 in 5 Californians with original Medicare, had this condition, and the individuals with depressive disorders likewise experienced 117% higher Medicare spending compared to the statewide average. In sum, across these conditions, cognitive and behavioral health conditions, the prevalence varied between 1 in 25 to 1 in 5. But Medicare spending was 100% or even 200% higher for the people with these conditions compared to the average spending in the state. And again, Medicare spending reflects out-of-pocket spending in the sense that it can correlate, but doesn't necessarily with out-of-pocket spending. These are instead the spending that Medicare is making on behalf of the individual. Now, on the next slide, we also looked at dual beneficiaries who have both the federal original Medicare program and the state-administered Medi-Cal program. Full dual beneficiaries, those with Medicare and Medi-Cal, who we discussed earlier, experience many conditions more often than other beneficiaries and had higher Medicare spending than other beneficiaries. This is also true of new full dual beneficiaries, and so we'll deep dive into the conditions that these 2 groups of beneficiaries who have Medi-Cal benefits as well experienced or were diagnosed with as of 2021. And we'll find some surprising conditions that were especially common among these 2 groups. Now, again, new full dual beneficiaries are Californians with original Medicare who started 2021 having Medicare only and not having Medi-Cal, but then by the end of 2021 had Medi-Cal coverage and had full dual benefits in both programs. On the next slide, we'll jump back to these cognitive and behavioral conditions. ADRD, Alzheimer's disease and related dementia, at the top here, affecting 18%, oh my gosh, affecting 8% of the population, and this is mislabeled here, and having a spending of 3.1 times the average statewide Medicare spending per person year of $14,525. So again, ADRD prevalence is 8%, and depressive disorders prevalence is 18%. So those are mislabeled on the left-hand side, but only on the left-hand side. Depressive disorders were diagnosed among 18% of the Californians with original Medicare, and the average spending for those with depressive disorders was 2.2 times the statewide Medicare spending. Drug use disorders, again, had 4% prevalence, and the average spending for those with drug use disorders was 2.6 times the statewide Medicare spending on average. Now, moving on to the next slide, we have further demographic differences for these three cognitive and behavioral health conditions. So there's a lot here, and I want to stress that we don't have to read through all of this, but among our findings about cognitive and behavioral health conditions among Californians with original Medicare, we found that 1 in 4 live with ADRD at ages 85 or older, and 1 in 3 live with depressive disorders under the age of 65. 13% live with drug use disorders at ages younger than 65, which is more than 3 times the overall prevalence, which again is 4%. And American Indian or Alaska Native beneficiaries and Black beneficiaries had higher rates of living with drug use disorder. Now on the next slide, we'll turn to the differences by gender and rural-urban geography. And here we're gonna have smaller differences in prevalence for these different demographic groups. And we'll express this in terms of percentage difference on the next slide. So we found higher rates of ADRD among women and in urban areas. And we found higher rates of depressive disorders among women as well. And lastly, we found higher rates of drug use disorder in semi-rural and rural areas compared to urban areas. Now, here's an example of regional mapping on the next slide, where we'll look at ADRD prevalence rates by covered California region. So note that the region covering much of Northern California, such as Mendocino or Jefferson counties, among others, have ADRD prevalence less than 6% among Californians with original Medicare, while in contrast, prevalence is highest and higher, in fact, than 11% in Los Angeles County. And again, the statewide average for this condition, ADRD, Alzheimer's disease and related dementia, is 8%. So in Los Angeles County, it's higher than 11%. Now moving to this next slide, we'll look at differences between full dual beneficiaries. Those are people who have full Medi-Cal benefits in addition to original Medicare, and Medicare-only beneficiaries who do not have Medi-Cal benefits. You see the prevalence and relative spending for full dual beneficiaries as the yellow third bar at the bottom of each condition group, and the Medicare-only beneficiaries in the dark blue middle bar for each condition. The conditions shown are the 5 with first the biggest difference between full dual beneficiaries and Medicare-only beneficiaries, and that also affect more than 5% of full dual beneficiaries, so 1 in 20. So for example, looking at the bottom condition, 27% of full dual beneficiaries live with depressive disorders, compared to just 14% of Medicare-only beneficiaries. The adjacent 1.9 times that you see right next to those 27% and 14% means that the prevalence of depressive disorders for full dual beneficiaries is 1.9 times that for Medicare-only beneficiaries. These conditions are notably associated with high spending. These are disorders, pneumonia, Alzheimer's disease and related dementia, pressure and chronic ulcers, and depressive disorders, as we just described. And full dual beneficiaries experienced even higher spending than Medicare-only beneficiaries did with these same conditions. So this is higher Medicare spending, and we're talking about total spending, not just the spending attributable to the condition. On the next slide, we have a similar chart, and that'll show the 5 conditions that are especially common among new full dual beneficiaries, and that affect more than 5% of these beneficiaries. New full dual beneficiaries are those who entered Medi-Cal during the year of 2021, and the comparison is with Californians with original Medicare overall. So for example, we see that pressure and chronic ulcers affect 12% of new full dual beneficiaries, which is 2.5 times the prevalence overall, which was 5%. We see that new full dual beneficiaries experience remarkably higher Medicare spending compared to the overall population with the same conditions. This is particularly notable here because each of these conditions is associated with very high Medicare spending overall, not just for new full dual beneficiaries. And new full dual beneficiaries may be entering Medi-Cal as a result of impacts to their savings and their disposable income due to high medical spending. So these findings highlight a frequent role of conditions that are associated with high medical costs in the time before Medicare beneficiaries enter Medi-Cal. And that's a notable finding here. And that wraps up our analysis of full dual beneficiaries, as well as of cognitive and behavioral conditions, with some regional mapping. And so with that, we'll turn to a summary of what we learned from across these 2 segments. So the top 10 most common conditions on the next slide, there we go. The top 10 most common conditions among Californians with original Medicare had prevalence rates that ranged from 18% for chronic kidney disease to 63% for high blood pressure. The prevalence of each condition varied by age, gender, geography, and race and ethnicity. And total Medicare spending for the individuals who experienced each condition varied widely. So, for example, we saw that those with anemia had 2.6 times the total Medicare spending on average per person year compared to all Californians with original Medicare. Medicare spending correlates with out-of-pocket costs that are faced by individuals. Many conditions, such as drug use disorders and dementia, Alzheimer's disease and related dementia, for example here, were especially common among full dual beneficiaries and new full dual beneficiaries. You can find additional detail in an upcoming chart book from the California Department of Healthcare Services Office of Medicare Innovation and Integration at this link at OMI's website. And then in the coming weeks, we'll have additional data from this study up on the open data portal that we mentioned. And you can find that by searching data.chhs.ca.gov. We're really excited to have shared this with you, and we'll be excited to share these slides. And what I think is important here is that we've covered a lot of ground, and thank you all for joining us in that. I know that it was a lot of data all at once across both prevalence and spending for these top 10 most common conditions, for the behavioral and cognitive conditions, and then also for the conditions that are especially common for dual beneficiaries with both Medicare and Medi-Cal. So thank you all so much. And with that, I'll hand it back to Anastasia, and we'll move to questions and discussion.
Thanks so much, Nils. If we could, let's take up that topic of spending. I think it would be helpful for the audience to kind of walk through, why did we choose spending as a metric? Is it because it's kind of the best way for us to look at sort of the intensity of care and services that people are getting? I think there could be, consideration, Medicare is a national program, so, we're all part of the same country, and what we have an interest in, seeing how does Medicare spend its funds. But I think that proxy for utilization is something that's especially interesting. So Nils, do you have some thoughts on that? What does CMS say? Not to speak for them per se, but how do we generally think of that spending as a tool?
Yeah, I think it's a really valuable question, and I want to start with, there's nothing more important than the individual experience of a chronic condition and of the experiences of managing it well and living as healthily as possible with the condition. The medical system and medical experiences that a person will encounter during their time with a chronic condition will vary. And so there's no one experience of a person, for example, with Alzheimer's disease and related dementia. But I think that the trends and averages do tell a story here about the kinds of experiences that may be encountered by the typical Californian with original Medicare who has a condition. And so if you're looking at stroke or trans-ischemic attack, for example, or you're looking at pneumonia, that may be associated with a hospital stay. It may even be associated with a nursing facility stay. And so these are experiences that take a person out of their normal environment and that are also associated with high spending and costs, not only to the federal program, but importantly to the individual. And so I think it's a next question to say what portion of this is being driven by higher acute hospital utilization or nursing facility utilization, and understanding the kind of drivers of Medicare spending. But as an overall kind of index of a combination of prices and the kind of care experiences that a person requires due to the combination of all of their healthcare needs and conditions, we chose to include it. And this is modeled after how the Centers for Medicare and Medicaid Services similarly publishes total Medicare spending by chronic condition. It's a really good question. I think future data analytics could look into teasing apart utilization and the kinds of services that people are requiring by condition. And then also there may be entities or organizations in the state, such as a hospital or such as a health insurer or other provider-led organization, that may be accountable for managing both the individual experience and the chronic conditions for a population, and also managing the Medicare spending. So an example might be an accountable care organization. And those organizations may be interested in where are we seeing the highest spending and where can we invest in preventive activities to bring down that spending while also improving the individual experience with that chronic condition or avoiding the chronic condition altogether.
Great. Dr. Perissinotto, I know you have some thoughts on Alzheimer's disease and related dementia, but before we get to that, any thoughts on the sort of, what does tracking spending mean, and how do we take that into context?
Yeah, I think tracking spending is really important. One, from the perspective of, are people getting the right level of care? I think, from a health system perspective, we tend to think, who are the costly people and why? But there's an important part, which is also, are people getting the services that you need? And so you wonder sometimes with some of the regional variations in urban and rural, is it an access issue? Is it the type of services that are available? Is that spending appropriate or not? And so I think that's some of the subsequent analyses that need to happen. I think, as Nils said, thinking about some of the conditions that occur that may be encountered during hospitalizations is huge. I'll say from personal experience as a geriatrician and palliative medicine physician who provides home-based care, we know that home-based care often gives people the right care at the right time in the right place and often is more cost effective. But how do you think about scaling some of these things at a more state level?
Right. Absolutely. And then did you want to share some thoughts about the Alzheimer's disease and related dementia figures?
Yeah, I'll say that I was a little bit surprised to see that it was quote unquote only 8%. And I recognize that that's all aggregate, which is all Medicare beneficiaries. Because certainly when you think about prevalence rates nationwide, they vary depending on the age groups, the highest age groups being those over 85, where you're more likely to see prevalences in the 30%. I think California was a little bit lower. I know that, again, from personal experience as a clinician and also someone who's done research in this area, we underdiagnose dementia all the time. I've done some smaller studies at UCSF looking at what percentage of people in this age group actually have dementia on a problem list. On the problem list is how things would then be submitted to CMS for coding, and it's vastly underreported. Why is that important? Again, it's important because you want to know who is suffering from dementia because of the increased Medicare spend, but also because of the burden of illness. And we know from a geriatrics perspective, once someone has a diagnosis of dementia, depending on the severity, we often have to rethink about how we manage those other chronic conditions. I am very intrigued about the map in LA. I'm like, what's going on with diagnosis in LA? I don't think everyone has dementia in LA. If so, I'm not moving there. I think it's more about how are we doing with diagnosis and coding. We do have an initiative across the state, as you all know, called Dementia Care Aware, which is really focused on educating the primary care clinicians that are really about diagnosing and providing the right support services. And then at the national landscape is the new guide models, which are the new payment models, thinking about those of us who are caring for Medicare beneficiaries with dementias, are we providing them the right care? So I'll stop there.
No, and that's a great plug for the guide model and thinking about that team-based care as well for people with dementia. Yes.
Exactly right.
Nils, could we go, or sorry, Cruz, who has control of the slides, could we go back to the slide that I think is talking about people who are newly eligible for Medi-Cal? Let's see.
I think it's a few. I think it might be maybe 10 slides past here, so into the future. Let's see.
So Cruz, go forward on the slide deck, please. Great.
And it's coming up, so I think it'll be 2 after here. There we go. 1 more, and then we'll do that.
Okay.
Great.
Yeah, and so again, there's what do we see in the data and what do we think it might be telling us? And you know, some of it we may not know for sure, but you know, in looking at this, I've been thinking about the journey that people make. Is it that they are they only have Medicare, and then they have some kind of an acute event, a stroke. You know, I think of pressure and chronic ulcers as not necessarily acute, but some kind of event that then they have a hospitalization, and then for economic reasons, they say, oh, you know what, I need to get Medi-Cal because that's going to help me with my copay, the coinsurance for this hospital stay. Or is it, I know some people wonder, well, you know, most other states and California now, we still have some asset limit, but we won't as of January 1st, 2024. But, you know, we talk about the spend down population, excuse me, people who they may not be at the income level, or they may be just above the income level for Medi-Cal, but they may also have some assets, and as they spend down those assets, they become eligible for Medi-Cal, and maybe they need Medi-Cal to help cover skilled nursing facility stay. But it's hard to tell from this data which population are we talking about. Maybe with the Alzheimer's disease and related dementia population, that could be. We had in our MLTSS and duals webinar back in August, we looked at the people with a share of cost who are in a skilled nursing facility, and those with a higher share of cost, they are not, you know, the vast majority. There's a fair number of people with Medi-Cal in skilled nursing facilities who have a very low share of costs. So, you know, again, the data doesn't always tell us, you know, one story. It tells us many stories. So anyway, Nils, do you have any thoughts about kind of the paths that may be seen in the folks that are displayed on this slide, or other data that we might want to look at to unpack this a little more?
I think this is a really important line of inquiry, and it's one that is, I think, every individual's journey through the medical system, or with a chronic condition, looking for a diagnosis or getting one unexpectedly, and then through to the care that they need as a consequence of that, which may include not just medical care, but also long-term services and supports, things like an in-home aid. those experiences are really varied, but may have commonalities for these individuals who are experiencing whatever pressures are leading up to entering Medi-Cal and gaining Medi-Cal coverage, which is also associated with becoming eligible, which involves, at the end of the day, a lower income or lower assets or total wealth. Before 2024, at least, that asset question will be an important part of it, especially for 2021, as we see in these data. So the long-term services and supports needs are going to be one part of it. The medical care expenses and long-term services and supports expenses may be a part of it. But all of this is an open question, and our curiosity is certainly piqued by this slide. I think that we were really excited to share these data with you. We think that this is a novel way of looking at it. But as you hint at or get at, Anastasia, this is a journey that each person is going down, and it's really a continuum of experiences. It's something that happens over time for a person where they may first need one type of care, but then develop an exacerbation and need a different type of care or additional types of care as they continue on. And so, just to kind of hint at this slide's meaning here, when we look at, for example, stroke and transischemic attack, which is that last condition category here in the bottom, the average per person year spending by Medicare for stroke or transischemic attack patients, people who experience it during the year, is $47,000, right? And then for people who entered Medi-Cal during the year, the average is $97,000. And so that's a really big discrepancy. That's that 2.1 times difference here that you see on the right-hand side at the very bottom. And it's an enormous amount of spending for a condition that is already associated with very high spending. But the individuals who are entering Medi-Cal during a given year are seeing distinctly high spending for conditions that are already associated with really high medical costs, really high medical care utilization. So those are things to look into. And this hints at it and kind of piques our interest, but doesn't address the final question in total. So I think this is a call to action or a call for further investigation.
Thank you, Nils. Dr. Perissinotto, do you have any thoughts on this, of what happens with patients? How?
I mean, I think my very high level is that our dual beneficiaries, whether they're just initiating or more, have an intersection of very high unmet social determinants of health or problems in social determinants of health, and how those interact with these chronic conditions are huge. And it goes back to what I said actually at the beginning of this, that where we are moving forward for California and older Americans is, what is our workforce in terms of interdisciplinary teams, and how do we care coordinate? Because there are risks and there are potential missed opportunities when we don't coordinate. And that is a multifactorial approach in terms of making sure our electronic medical records talk to each other, making sure we explain things well to patient. The number of, older adults that I've met that said, well, no one ever told me I had these conditions. So it just means that there's more coordination, but it's also a reminder, again, that dually eligible people are quite sick or at risk of significant complications, and it is upon us to really do right by them. I think that also means at a large level is looking at reimbursement models, both for Medicaid or Medi-Cal here in California, as we know that there's a shortage of providers more and more that want to see, unfortunately, Medi-Cal patients. Is that different when they're dually eligible? Yes, but I think there's just more room for us to continue these discussions at the state level.
That's a great point. And I think as we look at there's a targeted rate increase on the Medi-Cal side, how does that translate over to dual eligibles? We'll try to unpack that more next year.
And I think seeing examples where things have gone well. For example, we've seen the huge changes in hospice access and the provision of hospice care for Medi-Cal beneficiaries. And so if you take some of those models to see, well, how can we translate this to other conditions and not just in the last 6 months of life? But some more to come. This is always the great thing about research, as Nils can tell you, is that you do research, it tells you just need more research, but it's a great thing to start uncovering and answering some of these questions.
That's great. Okay, so we have 2 questions in the chat. One is about accountable care organizations, and those are, the acronym for those are ACOs, and they are a type of provider-led organization that Medicare, original Medicare, contracts with to kind of wrap the whole of care for that person, for that patient. But it is not the same as Medicare Advantage in that there's not, affirmative enrollment, supplemental benefits per se. Nils, is there anything more you want to add about ACOs?
Just that I'll share in the chat a really helpful explainer overviewing ACOs in California from the OMI website. And this includes counts of ACOs as of, the year varies, but as of 2021, I believe, for California by ACO type. So there are, within the Medicare program, there are different types of ACOs, some of which are more recent than others. And you can learn more about each of those types in that brief fact sheet that I shared in the chat. That is also from Anastasia and the Center for Healthcare Strategies. So.
Thank you, Nils. And then let's take a look at the next question in the chat. And not necessarily a question for Nils, but you may have something you want to chime in on this as well. But the question is, who at the state looks at the data from original Medicare and Medicare Part C, and is that data combined and analyzed so that practicing clinicians don't have to think about their Medicare eligible patient populations in buckets, or original Medicare versus Medicare Advantage? So good question. There's a few things to unpack. So we do have the state's version of an all-payer claims database that's administered by HCI at the state. And so there are, and I'm not sure if my team may have the link to put in the chat, but HCI, that's HCAI, they have a web page now that has combined both the original Medicare and the Medicare Advantage data and shows chronic conditions across both sets of data. There's some limits to the data set is not complete for all years, and we don't want to kind of confuse ourselves too much with saying, well, what's in this data set versus what's in our ATI slides. But anyway, there's a lot of great work being done at HCI that is really, I think, the beginning, and much more to come on the HCI efforts to combine the data. And again, so we have this data now. What do we do with it? How do we think about helping clinicians, planning for our overall healthcare delivery system, payment structures? There's a lot that we can think about here. So anyway,
and I'll just add to that, Anastasia, too, is that, I graduated a while ago, so I'm not sure what's being taught these days, but very little, unless you have specific focus on public health, did we learn as physicians payment models. In some ways that allows you to be agnostic to payment as a trainee and just learn how to take care of people. But as you move into private practice, whether it's on your own or in an academic institution or a community health setting, it's a little bit hard to expect the clinicians to understand all this. However, understanding the big buckets and understanding what are the quality metrics we're looking at and what are the different payers looking for, that's important. But there is this, the clinician community is pretty, this is an overstatement or an oversimplification, but is pretty far removed from understanding the intricacies of all this. And so I think there's a translation issue, which is why these talks are so great, is that how do we move from like, here's the payment, here's the data, here's the clinician, and putting them all together. So
great point. And great point also about quality measures. If we have different payment systems focusing on different quality measures, how can the clinicians figure out, okay, what should I especially focus on? Do I have to know which health insurance my patient has to know what to focus on? Yeah.
And can we expect our electronic records to do this and not just my brain, which is overstretched so often? Let me think about the things I really want to think about as a clinician and not which box I'm supposed to check, because that's not a good bang for your buck.
Right, right. Well, we have a lot of smart people here in California, such as yourself. So, we'll all keep working together and talking about it to look to those improvements. So we're close to wrapping up. Again, I'm glad we did the HCI topic came up because they're doing great work. And coincidentally, right after this webinar, I'm going to a meeting with the HCI team. So we are talking to ourselves within the administration here in Sacramento, and really glad to be talking with all of you as well, and folding in researchers, clinician leaders, and so grateful for both of you to be on this webinar today. We have again the folks who are on this call, vary across the roles they play and who they are in the health system, but for folks that do have Medicare, I want to remind you about HICAP, the availability of HICAP for help, or calling Medicare itself. And then we do have, again, the chart books, this most recent one that we will publish hopefully this week, and the others that we have had published in the past, they are on the OMI webpage. And a special thank you to the SCAN Foundation for funding ATI to do this analysis. Thank you, Nils and the ATI team. Thank you, Dr. Perissinotto, for your wonderful thoughts and engagement here today. And gosh, great presentation, great webinar. Thank you both so much. And we'll go to the next slide. Well, that's probably it. Okay. Well, thank you everyone very much. Have a good day. And this is the end of the webinar.